delegates, and those from national and international health agencies and donor agencies. Very good morning to you. And I bring to you greetings. And I'm so happy that Metin Gulmezulu is here from the WHO with his team. And bring you greetings from the Harvard School of Public Health, Boston, and JNMC. This presentation will focus on the magnitude of the problem, the role of checklist in healthcare, the WHO's quality improvement program, the pilot study of safe childbirth checklist in Belgaum district, and its impact at the health facility and in India. Globally, 303,000 mothers, 2.7 million newborns die each year, and 2.6 million are born dead, more especially in the low-resource settings in the world. And while the WHO estimates that MMR in India has reduced by 68.5% in the last 25 years, 45,000 mothers continue to die in India with a lifetime risk of death of 1 in 220, which is 25 times more than the developed world. And therefore, the WHO, and this in spite of the fact that we know what works, that we have simple, effective, easy to implement, and least expensive strategies to reduce both maternal and newborn deaths. And therefore, the WHO recommends that a skilled birth attendant must be present at every delivery, and that the National Health Mission stipulates that 80% of the deliveries should take place in the health facilities. Assuming, however, that the skilled birth attendants will utilize evidence-based interventions in their daily practice, but successful adoption of evidence-based practices in the health facilities to improve outcomes during pregnancy and childbirth is and continues to remain a challenge. And therefore, the WHO has developed a safe childbirth checklist to improve outcomes during childbirth in 2008, which is a tool to provide effective delivery practices and improve quality of health care at the time of childbirth, and which is a single sheet of paper folded once, which contains a list of best practices that need to be adopted during admission, delivery, before shifting to the, before shifting from the delivery room to the wards, and before discharge. Checklist has been used for a long time now, especially in the aviation industry and nuclear power sector for passenger and population safety. And in healthcare, it has shown to promote compliance, reduce errors, and improve outcomes and enhance patient safety. The WHO has also developed a safe surgical checklist in 2007 in collaboration with Harvard School of Public Health, which reduced adverse events by 40% and is being used in more than 4,000 hospital facilities all over the world. The Michigan ICU checklist also reduced by 2/3 central venous catheter infections. And therefore, we evaluated WHO's Safe Childbirth Checklist Quality Improvement Program as a single center pilot study in the second half of 2010 to evaluate the feasibility and acceptability by skilled birth attendants, its adherence to accepted standards of care, improve availability of supplies, and seek any behavioral change, if any, and measure its impact of the checklist. In a level 2 referral hospital, which is about 40 miles away from here, which had to be a rural facility, at least 250 births per month. Supplies had to be available for more than 70% of the time, and medical records would be available for scrutiny. Statutory approvals were taken from the ethics committees of the WHO, HSPH, and JNMC. District and state administration, also from the Government of India. We included only those birth attendants who were really involved in the birthing process. Written informed consent was taken from all birth attendants, administration, and obstetricians, and verbal consent was taken from patients because it was an observational study and not an intervention study. The sample size was 600, 300 pre and 300 post in duration of 6 months. In the pre-intervention period, data was collected for prevailing practices to prevent serious adverse events in the mother, the newborn care, and counseling regarding danger signs from admission to discharge, which are supported by patient medical records. The baseline data was collected on a pre-tested form by 5 nurse interns, who were identified by the principal of the nursing college in this campus, and who lived in the vicinity of the hospital, who worked in shifts for 24 hours a day, or during the 24 hours of the day, collected data by observations alone without any verbal contact with the birth attendants, and did an admirable job. And I think I must thank Sudha for allowing us to use these as data collectors. They were trained over a 1-week period with the accepted model of training by reviewing also the 31 items safe childbirth checklist and data collection at 4 critical junctures as mentioned below. Before the intervention started, we also trained the birth attendants with a similar protocol that was used for the data collectors. And daily monitoring was done by the chief medical officer and the senior anesthetist, as well as Dr. Honungar, the study site coordinator, during his weekly visits, who collected also the hard copies and brought it for data entry in JNMC server. There were 29 process indicators to evaluate the outcome, and we found some surprising results. The partograph, which was available also in the hospital, nicely stacked into the cupboard, was used in only 4%, increased to 42%. Hand hygiene and wearing of gloves before vaginal examination, before delivery, and sterile blade used for cutting the umbilical cord varied from 1, 10 to 12% respectively, which increased to 99%, almost 95 to 99%. Maxelf was administered only if indicated in 54%, which increased to 93%. It was given in 30% before delivery, 6% after. All of them have increased to more than 90%. Oxytocin was administered in only 8% within 1 minute of delivery to prevent postpartum hemorrhage, increased to 70%. and blood loss, which was measured in only 15 visual estimation, went up to 100%. As far as newborn care is concerned, keeping the baby warm and resuscitation care after delivery was only observed in 60% and increased to 98. Exclusive breastfeeding initiated within 1 hour was only in 50%, that increased to 94%. Counseling, which was given scant attention for danger signs as well as for contraception, increased to 95%. And attendance of birth companion present is generally a cultural norm here, which also increased to almost 100%. This pre-post study outcome showed that in the pre-intervention period, essential childbirth practices were practiced in only 10 out of 25, which increased during the after post-intervention to 26 out of 29, a 150% jump. And this attracted the attention of Times of India, which said adherence to 29 best practices improves hospital efficiency by 150%. The checklist that includes 29 best practices was tested by the Harvard School of Public Health and by the WHO in a hospital in Karnataka. This study also has some limitations. It is a pre-post study and a single center pilot study which may not be generalizable in the real world situation. The potential Hawthorne effect may have been, but then we have tried to minimize it by using data collectors who were present before and after the intervention. At the institution level, at this facility, checklist continues to be used during the last 5 years. From my reading in the last some years, that it was generally lasted for 18 months when you use such checklists. Especially it was used in the Michigan study, but here it has lasted for 5 years. The equipment and supplies has always been available except blood banking facility and the ventilator support. The stillbirth rate has decreased consistently from 23 in 2011 to 11.9 in 2015, with an average of 15.20 per stillbirths per 1,000 births. They had 2 maternal deaths in 5 years. This checklist has now been adopted by the Government of India. In its book on national maternal newborn health kit, toolkit in 13th November 2013, and a large multi-center trial is now taking place or is happening from 2012 as a better birth trial in Uttar Pradesh, one of the most populous and large states in North India, which has a maternal mortality ratio of 359 per 100,000, stillbirth rate of 27.7, first day maternal mortality 11 per 1,000 live births. Maternal near-miss deaths was not available. In 6 regions out of 18 in Uttar Pradesh, having 52 districts, it is a randomized cluster randomized trial in 120 facilities, 60 control, 60 interventions, with 172,800 outcomes, and the reproductive health outcomes assessed are maternal death, near maternal death, and ANMR at 7 days of life, and stillbirths of more than 28 weeks or 1,000 grams. Ladies and gentlemen, thank you for your patience.
midwifery lecturer, and she is also the admissions officer for midwifery in School of Health Sciences, University of East Anglia, Norwich of the UK. She has been Labour Ward Coordinator, Centre for Delivery Suite, Queen's Elizabeth Hospital in King's Lynn, and she has been awarded the Teaching Fellowship to investigate and research possibilities of using podcasting in teaching and learning in 2007, and she's going to share us how the curriculum changes were able to ensure better child health. Thank you.